Welcome to the module Complex Case Endocrine. I am Dr. Libby Johnson, a critical care clinical pharmacist supervisor and emergency medicine clinical pharmacist at JPS Health Network in Fort Worth, Texas. This presentation is part of the ACCP and ASHP Emergency Medicine Pharmacy Specialty Review course, which is designed for pharmacists seeking to update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. Our learn objectives today for our endocrine section are to interpret signs, symptoms, laboratory, and other diagnostic and acuity results, develop therapeutic and monitoring plans based on medication-related problems, patient and disease-specific information, and laboratory data, select alternative routes of administration based upon patient-specific factors, modify treatment plan based upon monitoring patients' response to initial therapy, and to develop education, discharge, and follow-up care plans based upon patient and disease-specific factors to improve adherence and continuity of care. We're going to start our endocrine section by focusing on adult diabetic ketoacidosis, or DKA, and hyperglycemic hyperosmolar state, or HHS, as I'll refer to them. Our patient case for our DKA section is CC is a 26-year-old male who was brought in by his roommate for altered mental status, shortness of breath, and nausea and vomiting. His past medical history includes type 1 diabetes, he has an essential tremor, and he's been in DKA only once before. His current medications include insulin detamir 20 units nightly, insulin aspart 5 units 3 times daily with meals, and propranolol 5 milligrams orally 3 times a day. Per his roommate, he had a cold last week, and since then he has not looked well. His roommate states he went to an urgent care where he received prescriptions for amoxicillin clavulanate and prednisone for 5 days. His vital signs include a blood pressure of 92/64, heart rate of 125, and respiratory rate of 28 times a minute. Pertinent laboratory values are as follows. His blood glucose is reading as high on his point of care test, so it's greater than 600. His sodium's 150, his potassium's low at 2.8, his bicarbonate's low at 12, his creatinine is elevated at 3.3, he's acidotic with a pH of 7.05, his beta-hydroxybutyrate is elevated, and as is his anion gap. For some background on DKA and HHS, both are life-threatening emergencies that can occur both in patients with type 1 or type 2 diabetes. They are both much more common, though, in those with type 1 diabetes, accounting for about 2/3 of our total cases. It's responsible for over $2 billion in healthcare dollars per year, so a significant amount of costs. And this has increased over time, especially over the last 10 years. There's been a large increase in our amount of we are seeing, most prevalent in the ages of 18 to 44 years old. It is the leading cause of mortality in children, and HHS is less common and accounts for less than 1% of all diabetes-related admissions when compared to DKA. When going over the pathophysiology of how DKA occurs, decreased insulin concentrations and increase of our counterregulatory hormones, including catecholamines, cortisol, glucagon, and growth hormone, over time lead to hyperglycemia. And when the body does not have insulin, your body essentially breaks down your fats to fuel itself. This leads to increased free fatty acids, leading to a buildup of acid in the body or ketosis. Now, DKA is different than HHS in the fact that in HHS, you do also have this relative insulin deficiency. However, there's still insulin circulating enough in the body to stop lipolysis from happening. Therefore, while you still get your hyperglycemia and you get your osmotic diuresis causing dehydration, you don't get the ketosis and the acidosis that you see with DKA. In terms of diagnostic criteria, obviously there's differences here as well, given their pathophysiology leads to different things. When we look at DKA, it's broken down into mild, moderate, and severe. All of them do have acidotic pHs. Severe DKA is defined as a pH of less than 7, moderate of 7.7 to 7.24, and mild of 7.25 to 7.3. Your bicarbonate is low, of course, in DKA. Your anion gap is going to be elevated. Urine ketones are, of course, going to be present. Your serum osmolality can be really variable in these patients, as well as mental status, with those in severe DKA having the worst of being in a stupor or a coma. Comparatively now, when you compare this to HHS, as I mentioned earlier, they don't get that acidosis, so your pH is going to be greater than 7.3. Your bicarbonate is going to be much higher as well. Your anion gap is really going to be variable. You should really not have many urine ketones since your body isn't in ketosis trying to compensate. However, the big difference with HHS is your serum osmolality. Whereas it really varies in DKA, it's definitely elevated in HHS of over 320 milliosmoles per kilogram. In your mental status with HHS, they're generally also in a stupor or a coma, just like in severe DKA. This brings us to our first question. So thinking back to our patient case, what is the most likely diagnosis for our patient case? A, HHS, B, hyperglycemia without acidosis, C, DKA, or D, influenza? And the correct answer would be DKA. He was acidotic. His anion gap was elevated. He had ketones present. I think his pH was all the way down to 7.05. So all the signs and diagnostic criteria of a patient in DKA. So your symptoms of DKA and HHS include polyuria, polydipsia, nausea and vomiting, weakness, dehydration because of the fluid shifts that are occurring within the body. You get Kussmaul breathing in these patients and often abdominal pain as well. So some of the symptoms are really non-specific. However, the Kussmaul breathing, combined with the polydipsia and the weakness, are definite key signs here in these patients. The most common precipitating factor for DKA is non-adherence to their diabetic regimen, with most often insulin. However, other stresses on the body can also precipitate DKA as well. Things like infection, myocardial infarction, stroke, pancreatitis, and also use of certain medications. So that brings us to our second question. So which of the following medications is contributing to DKA in our patient? Is it A, prednisone, B, amoxicillin clavulanate, C, propranolol, or D, empagliflozin? The correct answer is A, prednisone. He'd been put on it at the urgent care for that bad cold and cough he was having, and corticosteroids can definitely induce hyperglycemia and potentially induce DKA. Other medications that can induce DKA beyond corticosteroids include thiazides, sympathomimetics, pentamidine can actually induce DKA, atypical antipsychotics, and then much more frequently talked about recently in the literature, and especially in the emergency medicine component, is our sodium glucose cotransporter 2 inhibitors, or SGL2 inhibitors, are a known cause of actual euglycemic DKA, which we're starting to see more and more in emergency departments in the United States, which is posing an interesting challenge. Our management goals for DKA and HHS are to restore intravascular volume, correct electrolyte abnormalities, correct acidosis, and to correct hyperglycemia. To achieve those goals, management is really composed of three key therapies. Electrolyte repletion is important, the use of intravenous fluids or volume resuscitation, and then the use of insulin. And we'll talk more about each of these over the next few slides. So the first component we're going to talk about is electrolytes and their importance in these patients. Sodium derangements are common in DKA. Specifically, there's a dilutional hyponatremia that can be seen in hyperglycemic states. because of the osmotic shifts that are occurring within the body from the intracellular space to the extracellular space. As such, you may get that sodium back and be thinking, oh my goodness, we need to be cautious with our use of fluids and our correction because we don't want to correct the sodium too quickly, when really it's because of that hyperglycemia that it's showing this false low value. So there is an equation to correct for this sodium pseudo hypernatremia, if you will. So your sodium correction is your measured sodium plus your glucose level minus 100 times 0.016. So as you can see in a patient who has a sodium of about 120 and a blood glucose of 600, when you correct their sodium because of their glucose level, it actually comes out to about 128. So while yes, it is still low, it is not really as critical low as it's meant to seem. So it's really less of a concern when we're giving fluids. Potassium is another key electrolyte and must be monitored very closely throughout DKA management. Because you're going to be giving insulin and fluids and other therapies that can actually lower your potassium level, it's really important to be sure that it's at an adequate level during treatment to limit adverse effects, specifically arrhythmias. Often DKA patients, since they are an AKI and they are dehydrated, they do often come in hyperkalemic. So really the opposite problem, which insulin therapy is actually going to help with. However, you do get patients who come in with an actual low potassium level. And so insulin should actually not be initiated until their potassium level is greater than 3.3. And repletion should be done very aggressively in order to get it at an adequate level to actually start insulin. And along the same lines, while we don't want to start insulin until their level is 3.3, if their level drops during treatment, insulin should also be withheld as well if it happens to drop below that threshold during therapy. And so really ideally a serum potassium of about 4 to 5 should be maintained throughout DKA and HHS treatment. And that can be done through a combination of bolusing. It can be done by adding it to your maintenance fluids. There's several different strategies that you can use in these patients. The final electrolyte that is closely managed is really the use of sodium bicarbonate in these patients. Its use is really controversial in DKA. When you look at the literature that looks at the use of sodium bicarbonate in these patients, there's really been nothing to show that it benefits morbidity, no benefit in mortality, and it doesn't benefit the rate of recovery either. So the guidelines really recommend withholding sodium bicarbonate therapy unless their pH is less than 6.9. And really it's just recommended in those patients just because of the severe adverse effects that can occur with severe acidemia if it's left untreated. So back to our patients, so CC, so there was difficulty getting adequate IV access and fluid started. Patient's been here a few hours and now we have some new labs. So our blood glucose is still high, our sodium's 150, potassium's 3.0, bicarbonate 12, creatinine 3.3, pH of 6.8, and our beta hydroxybutyrate and anion gap are still elevated. So knowing this, which of the following is indicated to correct this patient's acidosis? Would you do sodium bicarbonate 150 milliequivalents in a liter of D5 at 100 mils an hour, sodium bicarbonate 150 milliequivalents in 1 liter of sterile water at 100 an hour, a sodium bicarbonate 100 milliequivalents times 1, or sodium bicarbonate therapy is not indicated? So sodium bicarbonate, 150 milliequivalents in 1 liter of sterile water at 100 mils an hour would be the correct answer. His pH is 6.8, so sodium bicarbonate therapy would definitely be an adequate option. And we, of course, wouldn't want to put our infusion in D5 since he is in DKA and hyperglycemic, and so that's just going to potentiate the problem we're already having. So the preference here would be to put it in sterile water to avoid that counteraction. The next management after electrolytes and DKA brings us to intravenous fluids. IV fluids are absolutely another key component of DKA care and can actually lower blood glucose to an extent just on their own and with their use. Initial fluid therapy should be 15 to 20 milliliters per kilo per hour, or about a liter to a liter and a half in the first hour, and that's if not more. These patients are often very fluid down and they really need adequate fluids as a part of their resuscitation. There is quite a bit in the literature, both outside of DKA and in DKA, looking at the use of balanced versus non-balanced fluids. And specifically in DKA, balanced fluids may help actually increase our resolution of acidosis and decrease the time that it takes to get there. So they can definitely be helpful within this patient population. So initial fluid therapy would be boluses. Continued fluid replacement after that really just depends on our sodium trend. Since, as we talked about before, sodium can be a bit altered in patients who are hyperglycemic, and then we're also giving them a lot of resuscitation. It's important to keep an eye on their sodium levels as we do go throughout treatment. So if their sodium level is normal and high for continued replacement fluids, we'd actually probably change to half. NS at 250 to 500 an hour. If the sodium level remains low, you can continue with NS or with other balanced fluids if you prefer LR. Plasma light at 250 to 500 mils per hour, just depending on the patient's weight, their renal function, how much fluids they need, and so on. And then finally, we have to consider blood glucose levels as well. So once, as we'll talk about, once an insulin drip is started, or once the serum glucose is decreasing, and once it reaches to 200 to 250 milligrams per deciliter, fluid should actually be changed to contain D5 at that point in order to continue to treat them until their acidosis resolves. And then the final component of management of DKA is, of course, insulin. For the majority of cases, IV insulin is the most appropriate. We'll talk in a bit about the use of subcutaneous insulin as an option. For IV insulin, we start IV regular insulin infusion at 0.1 to 0.14 units per kilo per hour. The insulin infusion should be titrated to provide a blood glucose decrease of about 50 to 75 milligrams per deciliter per hour, and that should be done per your institutional protocol. When the blood glucose reaches 200 and 250, as I mentioned before, the insulin infusion should continue. D5 containing fluid should be started, and then your insulin rate should be dropped to about 0.02 to 0.05 units per kilo per hour at that point. Because really at this point, once our blood glucose is low, we're just continuing the insulin and hydration until the acidosis is fully resolved. And then finally, the insulin infusion should be adjusted to maintain a glucose of about 150 to 200 until acidosis is fully resolved and the anion gap closes. And I do want to highlight here the importance of your institution having a clear protocol for insulin management. Pharmacists, of course, were accessible to help interpret the protocol, help nurses, physicians in any way we can, but it is really important to have safety guards around a high-risk medication such as IV insulin. So institutional protocols, utilization of barcode scanning and pumps are all key with managing insulin drips. You may be wondering, well, she didn't mention an insulin bolus. She went straight to starting an infusion. It's not that you can't do an insulin bolus or that I don't see it done often. There's really some key patients that I would do an insulin bolus in if there's going to be a delay in getting the insulin drip, or we're having compatibility issues or pump supplies or many other things that can happen in the ER. But it's actually been studied as well of whether or not patients actually need an insulin bolus. So in 2009, there was a prospective randomized single-center study of 37 patients. It was using regular insulin, and they looked at using a insulin bolus of 0.07 units per kilo, and then an infusion at 0.07 units per kilo per hour. And then the second group got an infusion, just an infusion at 0.07 units per kilo per hour without a bolus. And then the third group also received no bolus, and the infusion was started at 0.14 units per kilo per hour. The endpoints were time to resolution of DKA, peak free insulin values, and a decrease in initial glucose reading by 10%. For the results of this trial, time to DKA resolution did not differ significantly between the groups. So giving a bolus or not giving a bolus did not seem to matter. But what we did learn here is that the time for the glucose reading to decrease by 10% was actually longer in the group who did not get a bolus and was started at the lower rate of 0.07 units per kilo per hour. So while the guidelines still remain up and down about whether or not an insulin bolus is needed, they do state one factor of if you're not going to give an insulin bolus, then you do need to ensure you're starting your insulin drip at an adequate rate. So anywhere from 0.1 to 0.14 units per kilo per hour to start. Now, we talked about use of IV regular insulin, and all severe DKA patients should be getting that IV insulin drip. However, for mild to moderate DKA patients, you may actually consider using subcutaneous insulin. This could be potentially beneficial if you're having line access issues, if you prefer and your institution allows the patient to go to the floor with every 1 to 2 hour insulin dosing. That may, save a trip to the ICU depending on what your institutional protocols allow. And so the way you would do subcutaneous insulin for DKA management is you would use a rapid acting insulin as opposed to regular insulin, and it would be a 0.3 units per kilo subcutaneous bolus times 1. And then you would give 0.1 units per kilo every 1 to 2 hours. And then once the blood glucose is less than 250, you would decrease your insulin to 0.05 units per kilo per hour until the resolution of DKA. And all of that is giving subcutaneous insulin boluses as opposed to having them on an IV infusion. There are several studies looking at the use of subcutaneous insulin in these patients. The first one was in 2004, included 30 patients. They looked at using insulin aspart every hour versus an IV regular insulin infusion. The primary outcome was duration of therapy until DKA resolution. Secondary endpoints included length of hospitalization, amount of insulin administration until DKA resolution, and number of hypoglycemic events. The results were that there was no significant difference in the mean duration of therapy and no difference in any secondary endpoints. So really left it up to what was convenient for that patient at the time. Another study in 2011 included 50 patients. It was again an IV regular insulin infusion versus subcutaneous insulin Lispro every 2 hours. The primary endpoint was duration of treatment, and secondary endpoints included amount of insulin administered until DKA resolution, length of hospital stay, and number of hypoglycemic events. Results here were similar, so no significant difference in duration of treatment, no difference in secondary endpoints, but they did find that there was a greater length of stay and amount of insulin required in those with infection as the precipitating cause compared to those with poor adherence. And that, clinically makes sense given that they have an infection and an actual cause. And so we would need to be able to treat that infection probably before we're getting a great resolution of their DKA. So that makes sense clinically. And then the final study in 2004 included 20 patients, and it was an IV regular insulin infusion versus insulin Lispro. The primary endpoint was time to DKA resolution, and secondary endpoints included mortality, length of hospital stay, amount of insulin required, incidence of hypoglycemia, and the cost of treatment. The results here that there was no significant difference in time to DKA resolution, and there was no difference in secondary outcomes except for costs. The study did note, however, that the reason cost was significant between these groups is because those patients that were receiving IV infusions were required to be in the ICU. So it was just a higher bed cost, if you will. So really, the usefulness of subcutaneous insulin is trying to avoid, an ICU admission in your institution. And that just becomes down to which institution you work at. I happen to work at an institution where you can do IV regular insulin drips on our floors. And so most of our DKA patients do not come to our ICU regardless of severity unless they're, in a coma or needing intubation or other things. And so to wrap up, to compare intravenous versus subcutaneous insulin administration for adults with mild to moderate DKA, some pros would be that subcutaneous administration may allow for a lower level of care. It just depends on your institution, and that may lead to cost savings for your institution. There are no significant differences in overall DKA outcomes. It's low quality of evidence, but that seems to be consistent with what we're seeing in real time as well. The negatives, of course, if you want to call it a negative, so it is only for mild to moderate DKA. This would not be used for our severe population. And the subcutaneous route does still necessitate administration every 1 to 2 hours. So while it may save you an insulin infusion, it may be hard to get some of your floors to also have a medication they have to give every 1 to 2 hours and still monitor quite closely. So it may not even necessarily save you a change in level of bed care. So back to our patient, his labs, I'm just reminding you for what they were on our last update. So which of the following is the most appropriate intervention for our patient to manage their DKA at this time? A, start a regular IV infusion at 0.14 units per kilo per hour and titrate to our blood glucose goal. B, start a regular insulin infusion at 1 unit per kilo per hour titrated to reduce blood glucose to our goal. C, hold off on starting an IV regular infusion and replete their potassium to greater than 4. Or D, hold off on starting an IV regular insulin infusion and replete serum potassium to greater than 3.3. The correct answer would be D. His potassium was quite low, and so we would want to make sure to adequately repeat it to greater than 3.3 to reduce any chance of causing arrhythmias from lowering the potassium even further. So to wrap up our DKA management before we talk about HHS a little bit and their differences, DKA resolution is defined as a blood glucose of less than 200 milligrams per deciliter, plus 2 of the following: a pH greater than 7.3, bicarbonate less than 15, and ion gap less than 12. So back to highlight the difference in DKA and HHS, because now we're going to move on to HHS treatment. So reminding everyone that HHS, we do not get that acidotic state, and it's more a bigger problem of osmolality and fluid issues. So for HHS management, it's very similar to DKA. We use fluids in both of them. We make sure electrolytes are managed. We use insulin infusions. And really the key difference is that sodium bicarbonate therapy is not utilized on HHS patients, given, as we just talked about, they're not acidotic. When the blood glucose falls into a range of about 200 to 300, we add that D5 containing fluids. So that way we don't drop them too low. And resolution is defined by when serum osmolality normalizes, since they're not acidotic, so pH wouldn't be useful. Other than that, it's really the same concepts, and most institutions, including the one that I work at, we do use the same insulin protocol for both our DKA and our HHS patients. Now, once DKA and HHS are resolved, the patient can be transitioned to a long-acting subcutaneous insulin. When transitioning, the insulin infusion should be overlapped with the long-acting insulin for about 1 to 2 hours to avoid any rebound hyperglycemia and ketosis if they were in DKA. Well, there's a few options of how you can transition them back to a long-acting insulin. You can do it weight-based, so by calculating using their weight, so either 0.5 to 0.8 units per kilo per day, and you divide that between their long-acting and their short-acting insulin. Or you can use the last 6 to 8 hours from the rate of the insulin infusion they were on to estimate their total daily needs. Or you can utilize their home daily insulin dose if they were previously under control and say, they ran out for some reason or they had some other trigger causing the DKA. So now that we've covered adult DKA and HHS, we are going to focus on our pediatric DKA. Pediatric DKA is absolutely more difficult to diagnose, given that infants, toddlers, young children, they can't articulate their symptoms the way that adults can. So it is a bit more challenging, to get a good history to figure out what's going on. Kids do have a higher basal metabolic rate and a larger body surface area. So their IV fluid administration does require a bit of a greater precision. And we'll talk about some of the formulas we can use to try to estimate this a little better. Their cerebral and autoregulatory mechanisms are not as well developed. So we do have to be more cautious when we are treating our pediatric patients. They're already predisposed to cerebral edema, which is the most common cause of mortality in children with DKA. So we really have to watch those IV fluids, watch how much insulin we're giving, and watch really how fast we're treating these patients. And then finally, the high incidence of treatment non-adherence to insulin in adolescents is a huge concern, and counts for a huge amount of our DKA. Among the pediatric population, 5% of patients actually account for greater than 25% of the DKA admissions. So they can be a huge cost here in the United States. For our pediatric DKA diagnosis, so it's a combination, just like in adults, so hyperglycemia or a blood glucose greater than 200, acidosis, so a pH less than 7.3 or bicarbonate less than 15. They're in ketosis as well with urine ketones, beta hydroxybutyrates elevated, so similar to adults, what we saw. And pediatric DKA is broken down by severity, just as adults was. So there's mild, moderate to severe, and it's based on the level of their pH and how low their bicarbonate level is. So for management of DKA, we're going to start with talking about fluids in our pediatric side, just because we do have to be a little bit more precise with them. You really can use a lot of signs to assess severity of dehydration. Yes, we have, labs just like we do in adults, but they're not able to tell us, are you urinating a lot? What does your urine look like when you come out? And some of those nice history keys, they're not always able to get us. And depending on their age, the parents, may not be going with them to really know necessarily what's going on. So you really have to use other signs. So you can use things like skin turgor, mucous membranes, their heart rates, and other things like that to get a good feel of just what their severity of dehydration is. Obviously, once you get into signs of like weak pulses, hypotension, shock, that's when real bad dehydration and much more severe dehydration becomes a concern. Lab tests, of course, similar that we would use with adults, would be used, as well as ABGs, and then treating causes as appropriate, just as we talked about with adults as well. So for IV fluid management, if a volume expansion is needed, you can give them isotonic fluids of 10 to 20 mils per kilo over 1 to 2 hours. If their DKA is mild enough and they're not needing IV fluids, you can do this orally as well. It just kind of depends on the state of the patient. After their initial fluids are given, similar with adults where we gave a bolus and then we put them on a maintenance rate, you would do the same with our pediatric DKA patients. And then there's actually 3 methods for determining maintenance fluids needs in the pediatric population. There's the Holiday-Seeger formula, there's a simplified Holiday-Seeger formula, and then you can also do it based on body surface area for kids who weigh more than 10 kilos. All of these give you a pretty precise fluid resuscitation and a very clear amount of what they need initially in both per hour. So I really highly recommend utilizing those in your pediatric population. Just as with adults, electrolytes in pediatric DKA is just as important. Potassium is key. Just as in adults, kids can get arrhythmias from either a too high or too low a potassium level. They tend to be a little bit more lenient with it and don't have as many problems as adults. But just like with adults, really potassium needs to be repleted before you start insulin in these patients. The cutoff that the pediatric guidelines use is a potassium of 2.5. should necessitate delaying insulin and repleting until it's at an adequate level. Sodium bicarb, just as in adults, clinical trials have really shown lack of benefit from bicarbonate therapy. You can consider it in the setting of severe acidosis and life-threatening hyperkalemia. And the final mainstay of pediatric DKA is insulin therapy, just as it was in adults. For pediatric patients who are in mild to moderate DKA, or in whom, a continuous IV infusion is not feasible for one reason or another, you can do sub-Q rapid-acting insulin. Similar dosing that we saw, so 0.3 unit per kilo bolus, followed by 0.1 units per kilo per hour. And then, of course, if their blood glucose drops less than 250 before DKA resolution, you should decrease that insulin dose to 0.05 units per kilo per hour to keep the blood glucose around 200 until DKA resolves. So the similar issue that we saw with adults is once your blood glucose has dropped, you have to continue that insulin until their acidosis fully resolves. So sometimes you play this game of decreasing the insulin, increasing D5 until DKA is fully resolved in those patients. If they are in severe DKA or an IV insulin infusion is deemed necessary, it should start after adequate fluid therapy is given, since giving fluids can reduce your blood glucose just from giving that. You should not use a bolus in pediatric DKA patients. This may increase the risk of cerebral edema, so we do not use boluses in them, so that is different than our adults. And an IV regular insulin infusion should start at about 0.05 to 0.1 units per kilo per hour. So a little less aggressive with that initial dose also, just because of the risk of cerebral edema in these patients and wanting to keep a little bit a slower and closer eye on them. Our overall management goals are the same. So the insulin infusion should continue until your pH is resolved, your bicarbonate is up, and your anion gap is closed. Just as in adults, once oral intake is adequate and ketoacidosis has resolved in DKA, or serum osmolality normalized in HHS, you can transition off the insulin infusion. You also, just as in adults, you want to ensure that there is an overlap between the insulin infusion and the subcutaneous long-acting insulin, so that way you don't get rebound hypoglycemia. Long-acting insulin should be calculated as followed, so 0.3 to 1 units per kilo per day, and divide this up half as long-acting insulin and half as correctional. Or you can do it based on the insulin drip requirements, or you can utilize their home daily dose as we talked about earlier. For how the pharmacist can impact DKA and HHS management, of course, we can, as we always do, make recommendations to the team on how to treat. But our big role we can actually have is incorporating standardized protocols and order sets for DKA and HHS, working on those Alaris pumps, working on a set standard clear protocol that nurses can easily use and follow. And these can all lead to decreased times to anion gap closure, shortened hospital length of stay, and minimize treatment complications and adverse effects, preventing hypoglycemia, preventing electrolyte drops, having, a pre-built order set with insulin infusion, your BMPs that you need to monitor therapy, your blood glucose checks, your nursing communications, all of that is really key to making this streamlined for everyone to treat. Of course, we also serve as a resource for physicians and nurses, huge role in helping nurses with any questions they have on the protocol and how to proceed. We can also ensure that DKA and HHS therapies are readily available in the emergency department. Making sure that if you don't have insulin infusions in your automated dispense cabinets, that's a recommendation that you can push for, or if you happen to have your own pharmacy and IV hood in the ED, then making sure you're prioritizing those orders as needed, and just making sure that other things they need, such as potassium, bolus replacements, all of that would be available directly down in there without having to wait for it to come from pharmacy. And then finally, we can help with patient education as well. And same with on the discharge planning side, we can provide patient education on the importance of follow up, how to take their long acting insulin, and have those roles as well. And then we can also help with making sure they have follow up. So, do they need to have an appointment, with a pharmacist on the outpatient side to talk about their diabetes and how to manage things? So, a huge impact that pharmacists can have on these patient population. So, key takeaways from DKA and HHS: IV fluids and insulin therapy are the mainstay of DKA HHS treatment and should be initiated as soon as possible. Hypokalemia should be avoided during DKA HHS treatment, and insulin should be withheld until serum potassium levels are replenished. And implementation of a standardized institutional protocol for treating DKA HHS can decrease treatment errors and improve efficiency of care and patient outcomes. So, our next endocrine disease state is gastroparesis. So, gastroparesis, the delayed gastric emptying in the absence of mechanical obstructions. It's most common in those who have had diabetes for greater than 10 years, so it's a long term complication. And while we don't have a great understanding of the pathophysiology, it seems to be related to poor glycemic control, oxidative stress, and damage from hyperglycemia on our stomach lining and on our gastric area. In terms of treatment and prevention, dietary changes can play a huge role here. Smaller meals, decreasing fat intake, avoiding smoking and alcohol, all of those can help with your gastric emptying and help prevent delays. And there are some medications that can help as well. So, the first type of medication we're going to talk about are our prokinetics. So, metoclopramide, which is a dopamine agonist, and also happens to be the only FDA approved option for gastroparesis. Dosings anywhere from 5 to 10 milligrams, twice a day to 4 times a day. You should really limit therapy, really dosing as much as you can, just to limit side effects, since it can lead to dystonias, tardive dyskinesias. Metoclopramide does have quite a few side effects, and not only limit the dose, but limit the duration as well. So we really want to only have them on therapy for as long as it's needed and try to limit it as much as we can. The second prokinetic we have is our motilin agonist, erythromycin. Similar to metoclopramide, it does have quite a few side effects, so you do want to limit therapy also, both dosing and duration as much as possible. And with erythromycin, tachyphylaxis can also develop with prolonged use, so that is something to be aware of as well. Antiemetics can also help with gastroparesis. Obviously, it really only treats the symptoms. It's not going to improve our overall gastric emptying, but it's definitely can be considered in patients who are nausea and vomiting, just to help them get through in the interim as they need. Other things to consider in gastroparesis treatments are to consider non-opioid pain control. Opioids can further delay gastric emptying in these patients, so really we should try to use other options. There's many other classes that have, limited evidence, but they have evidence to help lessen abdominal pain via either smooth muscle relaxation or pain modulation. So we have like our anticholinergics like dicyclamine, hyoscine, antidepressants, and then finally gabapentin and pregabalin have shown some benefit as well. Now, on top of medications that we can provide to help to treat gastroparesis, it's also important to point out there are some medications to avoid in gastroparesis as well. Calcium channel blockers, antipsychotics, progesterone, lithium, and glucagon peptide agonists can all actually worsen gastroparesis. Obviously, some of these you're not going to be able to avoid, but limiting dosing as much as possible and limiting use as much as possible can be key in these patients. Our final section in our endocrine component is thyroid emergencies. And we're going to start with focusing on thyrotoxicosis. So thyrotoxicosis is any excessive amount of thyroid hormone resulting from overproduction, and that could be to many different things. So such as things like Graves' disease, which is one of our more common causes of thyrotoxicosis, just because it produces an excess of thyroid synthesis. Things like iodine exposure, goiters, stopping drugs, all of these, can lead to too much thyroid hormone from either inappropriate stimulation, continuous activation of thyroid hormone, excessive release, or exposure to outside thyroid sources like iodine. Thyroid storm is actually an extreme form of thyrotoxicosis. Its definition is kind of controversial, as there's no standard lab to tell us, yes, this patient is in thyroid storm versus another. But there is the Birch and Martovsky criteria. This is a many point scale that takes into account the following factors. So temperature, central nervous system effects, GI hepatic disorders, cardiovascular dysfunction, presence of congestive heart failure, presence of atrial fibrillation, and then any precipitating cause. And essentially, there's a breakdown of points for each of these. So if you had a fever, you would get more points. If you had a presence of atrial fibrillation, you would get points. And all of these you essentially add up. And if you have a score of greater than or equal to 45, it's indicative of thyroid storm. Now, in terms of how we manage thyrotoxicosis treatment, it is very manageable. We have the thionamides, propylthiouracil and methimazole. They both inhibit new hormone synthesis. It is important that these drugs be given early on in thyroid storm treatment, and they need to be given at least 30 to 60 minutes prior to giving any iodine therapy. Obviously, if you gave iodine, you would actually make the formation of more thyroid, which we would not want in these patients. So it's important to give these thionamides well before that iodine is given. When comparing whether to use propylthiouracil or methimazole, propylthiouracil does have the benefit of blocking the peripheral conversion of T4 to T3 over methimazole. So it may be a little bit more beneficial in these acute thyrotoxicosis patients. Iodine is your next mainstay of therapy. So as I mentioned, you give thionamides first, and then 30 to 60 minutes after the thionamide is given, you can actually give iodine. And iodine actually, in small amounts, would cause hormone release. But because of the Wolff-Chaikoff effect, large amounts of iodine actually block hormone formation and release. So it's a little bit interesting of a therapy. One tip I do have, so I tend to, when I'm managing these patients with the team, I make sure that thionamide is actually administered and charted on and given to the patient before I will even enter the iodine therapy into the chart. I know it's easy sometimes just to get all the orders in and just talk to the nurse about it, but I like to make sure that the thionamide is given, charted, and then that is at the point where I'll actually put in the order for the iodine in these patients. So just one tip, just to kind of stop them from being mismanaged and potentially getting the iodine before. Other mainstays of treatment for thyrotoxicosis, so we give beta blockers in these patients as well. Both for control of cardiovascular effects, since these patients do tend to be quite tachycardic, they can be in atrial fibrillation. But some of our beta blockers do also have the added benefit of decreasing your T4 to T3 conversion as well. So it may be helpful from that standpoint as well. Which beta blocker you want to use just really depends on physician comfort and what makes sense with that patient at the moment. Obviously, if they're looking a little bit more shocky, you're probably going to choose something IV as opposed to PO, and something short acting as opposed to long acting. And so because of that, esmolol may be a great use if the patient is, their vital signs are a little bit less stable. That may be a good benefit in these patients. IV propranolol is helpful since it does have that added benefit of decreasing T4 to T3. So we tend to use that as well a good bit, but it really just depends on the patient's clinical status and what makes sense at that time, beta blocker wise, um, for consideration. The next part of treatment is actually corticosteroids. So we want to treat concomitant adrenal insufficiency in these patients. And then some of them also have the added benefit of inhibiting peripheral T4 to T3 conversion as well. And then finally, there are some miscellaneous agents that we can use. So really none of these miscellaneous agents should be routinely used for the treatment of thyrotoxicosis. And it's really for patients that, one, are either refractory to all conventional therapy, or B, for some reason, can't have some of our conventional therapies if they're already, known hepatotoxicity or other issues. So lithium actually blocks the hormone release in these patients. You do target a level of about 0.6 to 1, similar for its other indications, but that would be an option for refractory patients. Cholestyramine can decrease the reabsorption from the enterohepatic circulation. So it can be helpful within these patients as well. I do recommend being cautious with your timing of cholestyramine, just because if you do happen to give it on top of the conventional medications, it may interact with those medications and lessen their efficacy as well. And then finally, antipyretics should be used to decrease fevers as needed. Really, acetaminophen is preferred just because salicylates can actually decrease thyroid protein binding and potentially worsen thyrotoxicosis. So we should really avoid salicylates within these patients. So that brings us to question number 5. So which of the following is correct regarding thyrotoxicosis management? A, iodine therapy should be given at least 30 to 60 minutes post-thionamide administration. B, lithium should be used as adjunct therapy in all thyrotoxicosis patients. C, if febrile, acetaminophen or an NSAID should be initiated, as well as non-pharmacotherapeutic options such as cooling blankets. Or D, steroids are administered in thyrotoxicosis to increase the peripheral conversion of T3 to T3. And so the answer would be A, iodine therapy should be given at least 30 to 60 minutes post-thionamide administration. So now the flip side of thyrotoxicosis is actually myxedema coma. So myxedema coma is an extreme syndrome of severe hypothyroidism that can lead to decreased mentation and hypothermia. Often presentation of hypothyroidism, it's often the initial presentation of hypothyroidism and can be precipitated by infection, stroke, myocardial infarction, and non-adherence or cessation of hypothyroid medications. Symptoms include fatigue, cold intolerance, dry skin, altered mental status, hypothermia, bradycardia, constipation, and alopecia. And common laboratory findings for TSH, it really varies, but of course T3 and T4 will be low. Often there's increased liver function tests. Often they can be hypoglycemic, and they can be anemic as well. The mainstay of treatment is replacing their thyroid hormone. So IV levothyroxine, and you give it at pretty adequate doses of 200 to 400 micrograms, and you continue that dose until their symptoms improve. If you have it available at your institution, you can also give intravenous T3 or leothyronine at doses of 5 to 20 micrograms. And then you also give steroid in these patients for concomitant adrenal insufficiency concerns. So for question 6, we have a 64-year-old female who was brought in by family for altered mental status. Only past medical history includes hypothyroidism on levothyroxine. She has not taken it recently as she ran out. On exam, she is cold to the touch, pale, and has a blood pressure of 94/74. Her labs reveal low T4. What treatment would you recommend to the team? The answer is D, IV levothyroxine, liothyronine, and hydrocortisone. So our key takeaways from thyroid emergencies are the Birch-Rorty criteria can be used to predict the severity of a patient's thyrotoxicosis. In thyrotoxicosis, thionamide should be administered at least 30 to 60 minutes before iodine therapy is given, and myxedema coma necessitates IV thyroid replacement until symptoms subside.